12 primary assessments, segment 2 of the assessment process. Remember that we just finished the scene size up, which that entailed everything from the time you're dispatched until basically the time you get on scene and you see the patient. Now, chapter 12 is the primary assessment. This is going to entail those first few minutes after you get on scene and you're with the patient. So this is kind of the critical component of the assessment process, because it's where you're going to make all your initial determinations as to the severity of the call, how sick your patient is, what you need to do immediately for life-saving measures, and then what your transport determination is going to be. So is this a load and go, or is this a stay and play type of situation? Not a real long chapter, pretty basic concepts, but we'll run through it here, and hopefully you get a good understanding. So then when you get on scene, the focus immediately is going to be on the life threats. And from what you learned in the CPR class, we know what ABCs are: airway, breathing, circulation. That's going to be the kind of the first concept that you use, is using those ABCs. Now the order of that is going to depend on kind of what your first general impression of that patient is going to be. So in CPR, we kept emphasizing it's CAB, so your circulation is first. If there's none there, then you start compressions. Now from an assessment standpoint, it's going to depend on, when you look at your patient, kind of what your determination is. If the patient shows no signs of life, you're going to jump straight to that C, because you might need to start CPR. If your patient is showing, signs of life, nothing too abnormal, then your first instinct should be to go to the airway and protect that airway. But it's all going to depend on that patient's condition, what resources you have when you get on scene, and then any of those other priorities that you determine as you assess that patient. So as with everything in EMS, there's a lot of circumstances, a lot of variables to your decision making. What we're trying to give you is all the tools to help you make those decisions. So like we just talked about here, and just to kind of reiterate, ABC depends on your initial impression of the patient. So when you walk in, you should be able to look at that patient, form a real quick general impression on the severity of what's going on, and then from there you'll decide. Signs of life, ABC. Appears lifeless, no pulse, CAB. And then you got to have those immediate interventions that may be needed, of which probably the most important would be to recognize that you need to start CPR. Remember, time is muscle. The longer a patient's down, the harder it's going to be to try to get them back. So the sooner you can recognize that you need to start that CPR, the better chance of survival that you're ultimately giving that patient. All right, first and foremost here, airway, protecting that airway. Any vomit, really any foreign object that enters the lungs, it's very serious. It can often be fatal. That's why there's so much of an emphasis when we talked about getting patients in the recovery position, suctioning them well. You don't want to have any sort of foreign material entering down into the lungs, because it's just a really serious condition. And then any extensive bleeding, you need to stop that immediately with direct pressure. Have a tourniquet someplace very accessible when you go in and you form that general impression. It might be something that you go straight to. Breathing and circulation are obviously vital for life. When we talk about transport destination later, you'll understand that there's just a few guidelines that absolutely mean you're loading that patient and you're trying to get them to more definitive care as fast as possible. Two of those are going to be breathing and circulation. So if there's problems with the breathing, if there's problem, what we'll say is problems with the pumping, that's a circulation problem. Those are the kind of calls that you don't mess around with. You want to get them taken care of right away, and get them, loaded either to a higher level of care that can tier with you, or get them to the hospital as quickly as possible. Now, if you get in there and you've done that quick forming that general impression, you discover, hey, there's nothing immediately life-threatening, which the vast majority of calls you go on, this is going to be the situation. Then you kind of shift that mode into, a couple other less urgent things like oxygen, evaluating them for shock, other interventions that you may need to perform, before you load the patient up. But kind of everything de-escalates a little bit to a little bit less severe thinking process. If you have those critical things, then time is of the essence. So the quicker you get things done, the quicker you get that patient loaded, the quicker you get them to the hospital, the better the outcome is going to be for that patient. So as we look at the primary assessment, these are the 6 steps. So you're going to form that general impression, and like we talked about, and we're going to talk about again here in the next couple slides, it's just a rapid determination based on what you initially see as far as how severe the patient is. And then you're going to assess their mental status, and we'll talk about an acronym that helps with that assessment. We discussed that you're going to learn all kinds of acronyms through this class. This will be an important one. And then we move into those ABCs, assess that airway, breathing, circulation. And then from there, you're going to determine that patient priority. So if you look at the primary assessment from a time standpoint, it's a matter of a few minutes. You should be able to do all of these steps in just a few minutes, and then you're moving on to the next component of the assessment. So whereas this is a very crucial piece of the assessment process from a time standpoint, it's really short. And that should just show you the importance that they take a whole chapter to teach you something that takes 2, 3, 4 minutes when you get on scene. So the general impression, you're going to assess that environment, and you're going to get the patient's chief complaint and their appearance. So the patient's chief complaint is what they tell you their main problem is. It's not uncommon that you'll get to the scene and people will say, I've got stomach pains and nausea and vomiting and a headache and this, that, and the other. Try to get your patient to narrow down what is the worst thing that you have going on, what's your biggest complaint right now, and that's what their chief complaint is. That's what you use for the chief complaint. Assess the environment they're in, kind of note what's going on around them, because that can clue you in. As soon as you hit the door and you see that patient across the room, just the environment alone should be able to tell you a little bit as to their general appearance. And then the appearance of the patient. As you do this job, the more you do it, the easier this gets. You'll be able to walk in when you become a seasoned EMS provider, and you'll be able to look at the patient and know immediately how severe it is, just on their appearance. We'll go through a lot of that as we work through the book and through the chapters, but understand that it is a crucial piece of this, forming this general impression. Based on what you observe and what you find out through that first process will help you determine the severity of the patient. And when we talk about severity of the patient, there are different ways that you can look at this. From a provider standpoint, is it critical? Is it non-critical? Is this a load and go, or is this I have time and I can do some things on scene before I need to load them up and take off? So that's going to help you set the priorities for your care and your transport. So here's the first image to kind of help you just think on what we've talked about already. So if you roll up on the scene, you get called to this little girl that's taking a fall, and you roll up and this is what you see. Kind of look at this and form a general impression based on what you see. I can tell you what I see is a girl holding a bloodied rag on her knee. She's obviously was roller skating on the sidewalk and took a tumble. But probably the most concerning thing that I would look at and see here is the red mark on her forehead, because that would indicate that she hit her head, that she wasn't wearing a helmet, and is there a risk for some sort of head injury with this? Now her eyes are open. I'm assuming she's going to be able to talk to you, but just that alone would probably be my biggest concern as I rolled up and looked at this. I wouldn't think that this would be a serious type of call where it's going to be a load and go unless you go to talk to her and she just is speaking gibberish to you. That would probably change your mindset a little bit. But based on what you see here, that's what I would say my general impression would be. All right, now we'll shift the focus on this primary assessment a little bit to spinal motion restriction, which this is going to refer to trauma patients when we're worried about spinal injury or the potential for a spinal injury. So in that situation, you're going to do what we call maintaining manual C-spine stabilization until you can perform more of the assessment. So you're not going to do this if you're treating other life-threatening conditions. The focus has to be on the life-threatening conditions, but you want to do it and try to prevent potential spine injury. But ultimately, if you have to put a tourniquet on, that's going to be more important than if they end up paralyzed. So that's one thing to keep in mind. You're going to apply that initial spinal motion restriction to the head and neck on first contact when you suspect they may have that injury. And then once you perform the assessment, you can always change gears a little bit. Maybe you'd end up not having to do it, or maybe you end up, all right, we're going to continue with the C-spine control. We're going to get a collar. We're going to put a collar on them, and then you're going to go through that whole process. But you're going to continue that throughout the call until you determine that it's not needed. All right, as we look at the spinal motion restriction, that C-spine stabilization, think about as you're sitting in a chair looking straight forward, head up, not moving it left or right. That's the position that you want to get it into. That you want that patient in a neutral inline position, and if they're in a sitting position, you're going to be behind them, kind of supporting their head and neck with a hand on each side. If they're laying down, kind of the same process, but you're going to be over top of them. This will be something that we practice this week when we do our hands-on section. We'll teach you how to do manual C-spine stabilization. It's all going to be situational. You're going to have to adapt to the scenario that you're placed into. If it's a vehicle accident and space is limited, you just have to do the best you can. And then as far as when to do C-spine and when not to do C-spine control, it really just depends on where you work, and every system is going to have different guidelines. I can tell you we have our own guidelines when we can clear C-spine, and it's a whole algorithm to do it, but it's simple things like it's age-based, it's mechanism of injury-based, and then it's range of motion-based, and you have to go through a few different steps to determine, all right, this person meets the criteria, we don't have to continue with C-spine stabilization anymore. All right, now we'll move into the look test. And in a roundabout way, I talked about it a little bit ago in the aspect of you're going to be able to walk in and get a feeling immediately once you've got a little bit of experience. You're going to be able to recognize things like the patient's color, the environment, how the patient's sitting, how the patient's acting. All of these indicators are going to help you determine the severity of the call just at a quick look. So basically you're getting a feeling about that patient's condition from the environment observations at that very first initial look. Your goal with the look test is to identify those patients that are going to be critical, the patients that you need to intervene with life-saving measures immediately or death is imminent. So you're looking for those patients that appear lifeless. You need to begin that resuscitation with CPR as quickly as possible. And as we talked about in CPR, you need to continue those compressions with as few breaks as possible for it to be efficient. Get that AED on there as soon as you can. That's the most definitive care for a patient in cardiac arrest, is to shock them back into a normal rhythm if at all possible. And then the other things we're looking for are those patients with an obvious altered mental status. So these are going to be the ones where the lights are on but nobody's home type of situation. They're not going to know what's going on. If they're speaking gibberish or making absolutely zero sense with what they're trying to tell you. And then you're looking for those patients that appear unusually anxious and with just a poor appearance, the ones that look pale and sweaty. What I can tell you is if a patient says that they feel like they're going to die, believe them. Usually when you get those truly sick patients, they know what's going on. Their body knows what's going on. I've seen things as crazy as a guy that come out with a suitcase once, and he said to the paramedic in the ambulance, "Well, don't you think we should get going here? I'm probably going to die." And literally, he went into cardiac arrest in the back of the ambulance before they got to the hospital, and it ended up dying. So if they have that abnormal anxiety, trust that there could be something going on. And the last few things that we're looking for with this quick look test, obvious trauma to the head, chest, abdomen, or pelvis. Those are going to be the critical areas of the body that are going to show, the most, I guess, impact towards leading to a poor outcome for the patient. And then a couple specific positions to look for. The tripod position is very common in somebody that is truly having difficulty breathing. So they're going to be in a seated position, usually with their elbows kind of down on their knees or thereabouts, leaning forward, kind of gasping for air because they can't get enough air into their lungs. Is a very obvious sign when you see it that they're in true respiratory distress. But that's what that looks like. And then Levine's sign is that patient that is just clutching their chest, complaining of severe chest pain or discomfort. That's also a pretty good indicator that they're having some sort of true cardiac event. So those are two positions that you look for specifically in this when you're forming this general impression. The chief complaint, like we talked about earlier, this is the patient's description of why EMS was called. It can be specific, it can be vague. From an EMS standpoint and a provider standpoint, try to get it to be specific. It makes the treatment process a lot easier. It makes transitioning care a lot easier. But sometimes a patient just can't explain things. And they might say that they're having a pain, but they can't explain it at all, or they're just not feeling good. But try to get them to be more specific and saying, I'm having abdominal pain, I'm having chest pain, I'm having shortness of breath. It's going to help you a lot more from a treatment standpoint. The one thing that I would tell you is don't steer patients down a specific path. Keep any questions, and this is going to be through the entire assessment process. Keep any questions kind of broad spectrum. Don't say things like, is the pain sharp? Because a lot of patients will say yes. And then when you say, is the pain dull? A lot of patients will say yes. Try to get them to describe the pain or try to get them to specify where the pain is. Just really try to get them to be specific. That's about all I can say with it. There are a few other pieces of information and things to observe when you're getting that chief complaint and forming that impression. Try to get the patient's age, their gender, and their position, because chest pain in a 20-year-old is a lot different than chest pain in a 60-year-old. So those are pertinent pieces of information that go right along with what they're complaining of. And then with that, you want to observe some things. So you want to listen for things like moaning, snoring, gurgling, respirations, just listening for anything that's abnormal to try to indicate what might be going on. And then in the same sense, smell for things. Smell for urine, feces, vomit, hazardous fumes, things that might clue you into why that patient could have the chief complaint. If they're complaining of abdominal pain and you smell feces, they kind of go hand in hand together. So it's just a number of pieces of information that you kind of want to grab all at the same time here. Here is that first acronym that we talked about. So as we assess the mental status of the patient, you want to remember the term AVPU. A-V-P-U. This is about as simple as it comes. A is alert, and I'll talk a little bit more about alert here in a second. But if they're answering questions to you, you don't have to wake them up. You don't have to do anything. They're completely alert. Verbal is that patient that they're laying, their eyes are closed, and when you start talking to them, they'll open their eyes and they'll start talking back to you. But if you stop talking to them, they might nod back off until you start talking to them again. That situation, the patient is alert to verbal response. Painful responses, when you yell at them and they still don't come to, you do some sort of painful response. And you are inflicting pain, but you're doing it for a medical reason. So we'll show you a couple different methods, but you can squeeze the earlobe. Sometimes that'll get them to arouse. More commonly, you'll put your knuckles right in the middle of their chest with a little bit of force and rub down, and that's called sternal rub, where you're going to stimulate them, and they'll, if they pop back up to that, then they're responsive to painful stimuli. If you do that, if nothing gets them to arouse, then they're unresponsive, and hopefully they're breathing for you, and just unresponsive. But if you can't get them to arouse no matter what you do, then they're unresponsive. Now, when we back up to the alert, there's a few specific things that we're looking at. Commonly, they teach you person, place, and time. So if they are alert, you would say they're alert and oriented times 3 if they know who they are, where they're at, and the time or the year. We also add event to this, and depending on where you're at, what system you learn in, that's not uncommon. So you might be alert and oriented times 4 in that situation. But for this textbook, it's going to be alert and oriented times 3. Now, a person generally loses these in a specific order, meaning a person can be alert and oriented times 3, alert and oriented times 2, or alert and oriented times 1, or just alert. If they're alert and oriented times 3, they know person, place, and time. Times 2 means they know 2 of them. Times 1 means they know 1 of them. Usually, the first thing that goes is time. So they'll know where they're at. They'll know who they are. They might not know what year it is. From there, they'll usually lose the place. They'll still know who they are, but they might not know where they're at or what's going on. And it's very common that goes in a very specific order. If you add the event one in there, that would be the first one to go. They might not know what's going on. But that is how it works. So what we're looking for here is, are they alert? And if they are alert and oriented, times how many? And then if they're not alert, are they alert to verbal, painful, or are they completely unresponsive? So AVPU, AVPU, AVPU. Assessing the ABCs, and like we've talked about it a couple times, it's going to depend on the patient's condition. But airway, breathing, circulation, you want to identify and correct any life threats, and then gather any information that's going to help you later on in the assessment. Gather information early and often, because you may not be able to gather it later depending on the circumstance. So if a patient's talking to you, try to get as much information out of them as you can while they're still talking to you, because once they go unresponsive, you've lost that opportunity to gather information. We're just kind of hammering home the ABCs here. Here's another situation looking at the photo. You walk into this. What's your quick general impression based on what we've talked about? I would say if you made the comment that it's a poor general impression, that would be very valid. He's lying supine on the floor, and does he have signs of life? That's something you're going to have to figure out. So you're going to scan the chest for breathing. If there's no signs of life such as breathing, or only those gasping, agonal respirations that you learned about in CPR, then check for a pulse. If there's no pulse, then obviously we move straight into CPR, and it becomes a cardiac arrest call. All right, with the airway, what you want is to be able to walk in and find that patient alert and talking, or if it's a baby crying loudly. If that's the case, you know the airway's open. When it comes to babies, a crying baby is a good baby because you know the airway's open and not compromised. If the airway is not open or it's endangered, then you need to take measures to open it. You need to clear any blockages. You need to remember BLS CPR when you're doing that. From the airway to the breathing, now you need to start thinking about situations where you might need to give your patient some assistance with their breathing. So is the patient in respiratory arrest but has a pulse? So you're not going to need to do CPR, but you're going to need to grab that BVM, start breathing for them. Hopefully they start spontaneously breathing, but otherwise you'll continue with that breathing for them until you get to a higher level of care. Are they not alert with inadequate breathing? So these would be those patients that have like agonal respirations, like we learned about in that BLS CPR, where they're breathing like a fish gasping out of water. In those situations, again, grab that BVM, give them some assistance. Is there some level of alertness but still inadequate breathing? Same situation. And then the last one would be they have adequate breathing, but the signs suggest respiratory distress or hypoxia. So based on what you observe, is there reason to believe that they're not getting the oxygen they need and that you need to give them assistance with that as well? So when it comes to breathing, these are the situations that you need to think about, and your assessment will dictate what you do. A couple slides talking about circulation here. Probably the big thing to know is what is good. So good circulation, the patient's going to be warm, they're going to be pink, and they're going to have dry skin. When we say pink, it's easy to assess that on a Caucasian usually, but if they have darker skin, you're going to look at their mucous membranes, maybe their nail beds, to see if those are pink, and that'll dictate kind of what their skin color is for you. If they're starting to get shocky, you're going to be looking for that patient that's pale. They're going to be clammy, so their skin is going to be kind of damp. It's going to be moist. It's going to be kind of like they are on a cool down after sweating, if you want to think about it that way. And then a quick visual just to remind you, check for a pulse, but we're not checking for longer than 10 seconds. If you don't feel a pulse within that 10 seconds, it's time to start into your BLS CPR. And then again, just kind of as a note, you're checking the pulse on, if you're checking a carotid like this, it's on the same side that you are. Don't reach across the patient where you can pinch off their airway. This is really the textbook way of how you want to check it. If you do feel a good strong pulse, then you move on to the next step. Kind of the things you're looking for with circulation when you're checking that pulse is it within normal limits? And we'll talk about normal limits coming up in the next chapter. But again, normal limits is going to be based on what your patient is, how old your patient is. Generally for an adult, that's going to be 60 to 100. And then you want to know, is it unusually slow or is it unusually fast? While you're doing this, you're looking for any severe bleeding. You want to make sure to control that severe bleeding. If you don't, you're going to start seeing some changes in the circulation that you'll have to deal with as well. So like we said, as we move through this chapter, just make sure at any point when you see life-threatening condition, you stop, you take care of that issue before you move on. The next segment here is going to talk about that priority and determining the priority of your patient. So now is when we're making some decisions as to, is this patient stable or not stable? if you find any life-threatening or ABC problem, as soon as it's discovered, you need to stop, take care of that problem. To be a stable patient, they need to have those vital signs that are within the normal range, or maybe just slightly outside of the normal range. Um, a good way to also measure this is ask the patient if they're able to, what's normal for them, because although a normal blood pressure might be 120 over 80 by the textbook, your patient's normal might be slightly different. So as long as they're within what their normal is, then you can still consider them stable when it comes to determining that priority. If there's any threat to the airway, breathing, or circulation, whether it's an actual threat or something that's imminent, it automatically rules them out of being stable. They move into the non-stable category. These are your load and go patients. These are calling for higher level of care patients. Um, you need to get these addressed right away. It's really going to be only so much that you can do from a treatment standpoint as an EMT basic. So you want to get them to a higher level of care really as soon as you can. And just to reiterate, you check that pulse. If it's not there, begin CPR immediately. Get that AED defibrillator over there. That's going to be the best course of action that you can try to reverse that. And then you just move into your BLS CPR that we learned a couple weeks prior here in class. And understand that you're going to assess the patient. You're going to make decisions based on what your assessment is. It's always not crystal clear, though. Sometimes you just have to use your best judgment. There could be a number of different diagnoses. Some are more serious than the other. Basically, you need to cite on the air of caution here. And if you think that there could be an issue, whether it's immediate or you think there could be an issue before you can get the patient to the hospital, upgrade that priority when it comes to transport. Better to get them sooner to the hospital than hold on to them and have something detrimental happen while they're still in your care. The quicker you can get the patient handed off, truly the better. And understand that things change. Your patient may be completely stable when you put them in the ambulance. Something changes and all of a sudden now you need to upgrade and run emergent, or you need to call for a tier. Whatever the case may be, you need to continue to assess throughout the entire transport so that when something does change, you can react to it whenever possible. Kind of the moral of the whole thing is initiate priority transport if there is a life-threatening problem that you cannot control or that you think will recur throughout the transport. Like we said, when in doubt, transport with an emergent response to the hospital. You can always downgrade if something becomes more stable, and vice versa is true too. If the patient goes downhill while they're in your care, you upgrade, you run emergent to the hospital. You need to continue reassessing while you're en route. Basically, the way we look at it from an EMS standpoint is if there's a problem with the thinking, a problem with the pumping, or a problem with the breathing, it's an immediate transport. Those are your high priority patients that you need to get to the hospital as soon as possible. So thinking, pumping, breathing, get them to the hospital. So just to think about this and to hammer home what we've been talking about, the reevaluation of the primary assessment. Why is it important? Why do you keep doing it? Just understand things change, and you need to be able to adapt to those changes, but you need to be able to see those changes as they happen. If you're not paying attention to the patient, it's easy to have something bad happen that maybe you miss, and you don't want to be the reason that something detrimental happens to that patient. So always be observant, always be reevaluating through this primary assessment. And then a little something else to think about here, but how is that primary assessment different for a child compared to an adult? So based on your findings, when you perform this primary assessment, what are some differences that you would see from child to adult? So things like chest pain in a child versus chest pain in an adult are completely different. Things like a pulse rate of 130 in a child versus a pulse rate of 130 in an adult are going to be completely different. And as we work through the textbook, you're going to understand a lot more of this. And just know that everybody's different. Everybody has different normal ranges, and you have to work within what those are. Now, as we look at these characteristics and that primary assessment, just understand that everything takes different forms. Every situation is different. The characteristics of the patient are going to be different. Is it a medical versus a trauma? What's their level of consciousness? Is it an adult? Is it a child? Is it an infant? Basically, you need to know every call is going to be different. There's going to be a lot of similarities from call to call, but every call is going to be different, and you have to use the tools that you're given and the assessment that you perform to make transport decisions and to make treatment decisions for that patient. So as we get to the chapter review here, just remember this is a short segment in the actual call process. It's only going to take a few minutes. You're going to walk in, you're going to form that general impression. You're going to determine their level of consciousness by using the AVPU, alert, verbal, painful, or unresponsive. You're going to determine what their ABC status is, and then you're going to determine what your transport priority is. So just a handful of steps in a short period of time, but there's really a lot of information that goes with those few steps. So as you move through the chapter review, again, remember, if it's important enough to be in the chapter review, it's important enough to be on the quiz, or I guess in this situation, this chapter will probably be more of an exam. It's going to be a little bit longer. The next segment will be a little bit longer than the first two. And it's an important one because it's all of the vital signs and monitoring. They're hard skills to pick up on. It's a lot of what we'll practice in the next in-class session, and we'll move from there. Hopefully you're getting a grasp on the assessment process. The first couple steps, pretty straightforward, but important. Just remember, it's very systematic. You work your way through each call pretty much the same. And then you're just plugging in different information into your knowledge bank as you move through the assessment process.